Hi, and welcome to the IAPB Eye Health and COVID-19 web series, where we invite experts from across different areas of health and development to discuss key issues during the current pandemic. I'm Jessica Crofts-Lawrence, the Head of Policy and Advocacy at the IAPB. Today's interview is part of a series of discussions we're having to understand the way the eye health sector is responding to the challenges in operating during the pandemic and adjusting to the new normal. I'm delighted to be joined today by Dr. Rohit Khanna from the Prasad Eye Institute in Hyderabad, India. Dr. Khanna is an Associate Professor of Ophthalmology at the School of Medicine and Dentistry at the University of Rochester in America and a Senior Visiting Fellow at the University of New South Wales in Australia. His clinical areas of interest are cataract and glaucoma, and he is involved in training and research, especially related to public health. He has made over 150 presentations at national and international conferences and given many guest lectures. Dr. Khanna is also a board member of IAPB and is currently serving on IAPB's COVID-19 task force, helping us to develop some strategies and guidance around restarting eye care advocacy programs and services in the context of and as we emerge from the pandemic. He also serves on the COVID-19 task force at Prasad, so is extremely well placed to speak on this topic today. Welcome, Dr. Khanna. So we've all had to adapt during the COVID-19 pandemic, but there are obviously particular challenges which come with running an eye facility and delivering care. What changes have Prasad made over the last few months, and what have been the strategies that you've adopted in order to be able to operate during COVID-19?
Thanks, Jessica, for that brief and comprehensive introduction. What I will divide this section into, like we had, India went through different phases. One is pre-lockdown, and then we went for one of the biggest lockdown ever in the world. And then we started opening up, recently we started opening up our services. So when we had the first case in India in late January, so our hospital infection control committee geared up, and started developing protocols and working on ensuring that we are prepared before the pandemic hits us. And the first case in Hyderabad was on early March. So at that time, I think again hospital infection control committee met, and we had a nodal person who was in charge for the operation or entire hospital infection control committee. Then we had a strategy committee, and then we had an execution committee. So each and every person roles were clearly defined. And also we worked on development of guidelines, and also we followed all the government advisories on this COVID-19 pandemic in India. Immediately what was done was communication was sent to all patients through all channels to reschedule non-emergency appointments, because we have patients traveling from all over the country and also internationally. So we made sure that people don't come for non-emergency care and they can be taken care at their doorstep wherever they are staying. And we started educating the patients as well as staff for prevention against COVID-19. And also there were quality control measures to look at the assessment of compliance to protocols by the staff. So all this happened in just a span of 20 days. And India went into lockdown on 23rd of March. So we had hardly 15-20 days with us. So the lockdown first was announced on 23rd of March, which was for 3 weeks till 14th of April. And then subsequently the lockdown was extended beyond that from 15th April to 3rd May. So these two phases are called lockdown 1 and lockdown 2 in India. At that time, all the elective procedures were stopped. So the government advisory was to stop all elective procedures and only take care of emergencies. So we were only taking care of emergencies. So at that time, we started teleconsultation services. And as we are moving along, we are building upon it and strengthening the teleconsultation services. What we did was we made phone calls to all patients in rural areas during this lockdown to assess their well-being. And also beyond eye care, what else they need actually. So we also assess their daily needs, and those in distress who were in need of their daily need, foods and other supplies, our team went and provided them at the doorstep. And our rehabilitation team also was quite active at this time, and because patients with disability need to be taken as proper care, and because for them implementing all the protocols for COVID-19 or getting adjusted to new normal is new challenge. So our team helped them, and our team took care of all the clients who were with disabilities and all. And so this was at the patient front. And then as it was lockdown and all the staff were at home, so we used this opportunity. We didn't sit at home idle. So we used these opportunities to develop our education materials, online lectures, did a lot of webinars, and we wrote a lot of manuscripts also. A lot of pending manuscripts were there, a lot of papers were there. So everybody was working on that, and I think we did a good amount of work on that, and we were quite delighted with the amount of manuscript what we wrote. So this was like when India wasn't completely locked down, and then the government advisory came that from 4th May you can open up regular service also. So we didn't want to start in a haste. So this lockdown period was also used to strengthen our protocols, our patient care protocols, our patient safety protocols, our staff safety protocols. So we wrote all that, and the draft of these protocols have been sent for publication. And we also worked with different societies, including All India Ophthalmic Societies, to develop protocols for different conditions, different specialties. So that was all happened that time. And when we opened up on so this is when we opened up from 4th May. So it was called lockdown 3. It was still not completely open. There are only certain services which were open. So lockdown 3 was from 4th May to 17th May, and which was extended from 18th May to 31st May. So this was lockdown 3 and lockdown 4. So in lockdown 3 and lockdown 4, which was from 4th May to 31st May, in 2 shifts, we developed 3 teams who were working in shifts. So the entire team was not coming to the hospital. And we also developed additional guidelines because staff was coming. So what should be protocol for staff to come to the hospital? How should they come? What should they do at home? If somebody is traveling out from other state or from other city, what protocols they should follow? So all that was laid down and implemented. We also worked with national and state societies to develop different guidelines. So there are this issue of Indian Journal of Ophthalmology in July issue had a lot of guidelines for different specialties, which many of our faculty participated in that. And then subsequently, we also started having daily performance review as well as review meeting of the top leadership of the organizations. So every week, the top leadership of the organization used to meet and discuss all the strategies, all the patient care strategies, operational strategies, funding strategies. So multiple things were discussed at that meeting, and the daily performance was reviewed very closely on day-to-day basis. So this was lockdown 4, which is like say from till 31st May. So India in fact was completely locked down from 25th March to 3rd May, and then from 4th May to 31st May was some relaxation in lockdown, and then started unlocking from June 1st. They called it as unlock 1 from June 1st to June 30th. So from 3 teams, because now the patient footfall started increasing because the transport had started, some of the airline services have started, some of the trains have started, some of the public transport have started. So what we did was like we made 2 teams because we anticipated that the patients who are waiting in April and May, we will see a rush of these patients who require some services. So in our eye health pyramid, we have a center of excellence at the top, which is the Apex Center in Hyderabad, and then we have 3 tertiary centers, and then we have centers in the rural areas. And then we have at the bottom of the pyramid, we have vision centers. So what we saw was like the patient footfall started increasing, but not to the pre-lockdown era actually. So pre-lockdown, we used to see on an average 1,500 patients daily in center of excellence. And so what we saw was like almost 40-50% of what we used to see pre-lockdown in center of excellence. In tertiary centers, we saw 50-55% of our patients, what we used to see pre-lockdown. At the rural areas, we could see almost 70-80% of pre-lockdown patients. So what we saw was like, as the services moved closer to the doorstep, the number of patients we saw, the footfalls increased more in the rural areas and less in the urban areas. So at the same time, when the staff was joining, when the patients flow increased, so we had to be more stringent with the protocols, quality monitoring and all that. So that was done by the Hospital Infection Control Committee. And so that we don't encounter any patient or any staff. Even protocols were laid. If a staff is suspect, what should we do? If a staff is positive, what should be done? If a patient comes who is positive, what should be done? And recently we are also discussing, and we are going to implement in a week, about testing protocols in all the facilities, so that any patient who come can get tested, any staff can get tested. Because what is happening is like a staff is suspect or somebody has fever also. It can be any fever, but we had to send them for quarantine and all. But once we start in-house testing facility, then probably I think that would be minimized. So in a week's time, in-house testing facility, which is a rapid antigen testing facility, will be started in-house. We're not starting the RT-PCR thing, but we're starting the rapid antigen testing facility in-house in our hospital. So these are some of the things which happened during COVID-19, and it's still ongoing. So we are also learning as we move along. We are learning, and the protocols, the governments are also changing the protocols. Advisories are changing from day-to-day basis, and we are also following them very closely. And we are also making modifications in our protocols. We never thought that in the beginning that we'll ever do testing, but now we are in the stage that we can do a testing to all the patients who come to us if required.
Thank you, Rohit. And you mentioned just there actually the reduction that you have seen in the number of patients coming to seek eye care services. I wonder if you could tell us what you think the impact of COVID-19 has been, not just for LV Prasad, but also for eye health delivery more generally.
The biggest impact of COVID-19 was on the patient care. The biggest impact of COVID-19 was on patient care operations across the country actually. When we spoke to a number of ophthalmologists across the country, everybody is impacted. It's not only ophthalmology, but many other specialties are affected. And not only healthcare, but many other service delivery organizations are affected. So I think almost 80-90% of sectors are affected with COVID-19 in terms of the clientage or number of patients they see. What we saw was like during the lockdown, like the total number of patients we saw in that period from say 1 month of lockdown, nearly 1 month of lockdown, is equivalent to what number of patients we would see in one day. So in fact, like the biggest impact was on some of the emergency services like keratoplasty patients who could not come, the patients with ocular cancer who could not travel. So these are services which are not emergency, but they require regular ongoing care. In fact, they were also impacted a lot, which was quite painful to see, but that was the fact actually. So all the international patients were could not travel. Patients from other cities could not travel. So almost like our operations were reduced to almost like say 99% during lockdown. And when the lockdown was relaxed a bit, then we started getting almost 20 to 30% of our total operations. And now we are almost like 50%, approximately 50 to 60%, I would say, for total operations. But that's the overall impact. And at the same time, there was most of the international funding is being diverted to COVID-19. So many of the funding agencies are like keeping it on hold. The financial sustainability was impacted in the beginning. But I think one of the positive message from the chairman, like there won't be any cut in salaries and no one will lose their job, was a very positive message, which infused a good lot of energy among the staff that none of them are going to lose their jobs and none of them are going to have cutting their salaries. But at the same time, we decided that we'll stop all the new recruitments. So that and try to manage with whatever people we have and try to make best use of the available resources and time what we have. So these were like some of the major impact, not only for us, but I think it was uniform across different organizations, different sectors across the world.
And what strategies have you adopted during COVID-19?
With the COVID-19 outbreak, one thing was clear that we will not compromise on any of our values. And we also decided that we will not spend what we don't earn. At the same time, we don't want to keep any payment pendings because for any vendors. So we decided that if we give all the payments what is pending for the vendors, then we'll know what we have so that we know what we can spend. And as the patient care operations came down, we started looking for alternate source of revenues from technology, from electronic medical record, from engineering products. We also worked on reducing our expenditures in terms of travels. We negotiated with a lot of our clients for rental reductions actually. A lot of our like property owners, like we have many of the properties which are rentals. So we started negotiating with them for the reduction of the rentals. So, and we were fortunate that many of them reduced our rent, or some of them even refused to take rent. We started using technology to the optimum to bridge the gap in access to care, because many of the patients who could not travel. So we started connecting them through technology, through electronic medical record system, through teleophthalmology. But at the same time, we didn't compromise on our values of giving free service to those who require free care. So at the primary care, everything was free, and that continued. So nobody was denied care because of lack of funds or lack of resources with them. These are some of the things which we practiced even when we were in crisis, so that it was very clear that we will not compromise on any of our 5 values, which we are proud that we adhere to all of them. And hopefully in future also we'll continue adhering them.
And Rohit, I mean, it's great to hear you mention some of the kind of small positives, for example, that you didn't lose any of your staff during this time. I hasten to say opportunities, but have there been new pieces of work or things that you've done that have been the kind of silver lining that have come out of this pandemic?
What came out from this pandemic was like our innovation team started working on developing new products. So they developed an in-house visor, which is freely available on the web, and anybody can make it. And we started supplying many people across the city as well as the state. And they also started developing multiple other products. They are working on them. We also started doing home consultation for patients. So same thing like Amazon home delivery, or so this was like a eye care delivery at doorstep. So in the rural areas, anybody who is 60 years and above, because the most impacted people from COVID would be 60 years and above. So there may be a fear in them not to come for eye care or health care. So we started offering them services at home. We did a pilot in two of our primary eye care centers. And we are glad that many of the patients used to call for eye care, and their children used to call and say that our parents require eye care, can you go at home and do it? So with all the protocols what we follow in the hospital, we followed the same protocol so that they feel safe and secure. And in turn, what happened is many of the neighbors also wanted to come and get eye checkup done. So all the family members got their eye checkup done, and all the neighbors also came and got free eye checkup. So this was absolutely free. As I told, we started using technology to the optimum. We started teleophthalmology services. It is getting strengthened day by day. So many of the follow-up patients now we are calling on teleophthalmology consultations. So when we do a surgery, we don't have to see them every 1 week or one second day or third day. We just tell them that 1 week you come and do a teleconsultation, and then you can come for a 1 month follow. Other thing what happened is like it was a boon in disguise that because of COVID-19, eye camps were totally kept on hold. So there was no eye camps happening, and we were very fortunate enough that we never believed in eye camps. We believed in setting up permanent facilities in rural areas. So we had almost 20 secondary centers and nearly 180 plus vision centers in these rural areas, which are permanent facilities, which helped us. So we were at the doorstep of the patient from the day for many years. So I think instead of like stopping camps and looking for other alternative measures, I think this permanent structure in rural areas helped us a lot in reaching our patients and fulfilling our commitment to serve them. So that was one thing. And in terms of surgical protocols also, we didn't have to change much, because the protocols what we used to follow from day one is equivalent to what many of the affluent countries, and sometimes better than many of the protocols in some of the facilities in these countries. So fortunately, we don't have to change much in our protocols. It's a few twisting in terms of using of PPE and all that kind of things, especially in the aerosol generating procedures. Otherwise, not much change in that kind of protocol. So we don't have to make a major change there. And also we started talking to patients, our patients who are happy, and we were willing to accept small donations also, like 1 day consulting fees, starting from a day consulting fees to as much as they can pay. So we were fortunate enough that some of the patients came forward looking at this. They came forward and donated in kind or in cash. In terms of like some of them donated PPE for some centers. So that kind of in-kind donations, or sometimes small donations in terms of like some small financial donations. So we are fortunate in that way that our patients are quite understandable, and they are quite happy with our service.
And Rohit, what do you see as the role of eye health and eye health organisations, both during but also as we emerge and start to recover from the current pandemic?
I think as we recover from the current pandemic, I think things will never be same as what it was before the pandemic. So there will be some changes, and everybody has to adapt to the new normal way of living. Patient care revenue will continue, but I think one should look for different streams of revenue generation also. Like look at technology, look at innovations. most of the eye organizations are depending on the soft money, which we call as funding from international organizations or government funding, and the moment the funding stops, they tend to collapse. So I think most of these organizations should learn that they should reduce the dependence on soft money and try to sustain themselves with the patient care revenue and generate other sources of revenue. And if you get a money from the different funding organizations, you can use that money for your capital growth rather than using them for your day-to-day operations. Also, we feel that we should get out of the traditional way of thinking that as an ophthalmologist, you just think of clinical care, that you go see patients, operate, and then that's all. But I think you should start venturing into new areas in eye care also, like public health is one area. You can look at research as another area. You can look at education. You can look at innovation. You can look at technology. So there are different areas you can spread into. So I think people should get out of the traditional way of looking at eye care and start looking laterally in different domains. We should also start advocating with government for investing in healthcare, because many of the developing countries, the investment in healthcare is meager. So I think a strong advocacy with government to invest in healthcare in developing countries would go a long way. As the CAM-based approach will no more be viable in near future, so we should start developing permanent facilities in these rural areas, which we did in some of the places. But I think for a country like India, we require a lot of places, a lot of facilities in rural areas, and we should start working towards them. So I think, yeah, that's all.
And finally, Rohit, what have been the key lessons that you've learned during COVID-19?
One word answer for that is like, what is essential? I think we learned the meaning of word essential. So we don't require so many things to live in this on this planet. So that was on the personal front what I learned, and many people might have learned that also. And what we learned was nothing is permanent. We never thought that the patient care will fall so much that we have to depend on alternate source of revenue for our incomes. So I think one thing we learned is nothing is permanent. Even patient care can go down. But at the same time, we learned that we should look for opportunity in adversity rather than crying about it. And as I pointed out, we should look after developing permanent structure in the rural areas, and instead of the CAM-based approach. We should think a different way of normal and try to work on them so that in near future we are prepared for any other future pandemics which may come. So we were not prepared for this pandemic, and because of which we are facing all these problems. So I think this pandemic should just give us a good lesson for us and for future generations to come, like how should we face a pandemic, especially in the healthcare sector for us.
Thank you, Rohit, and thank you for all your fantastic insights today. As you say, it's really forced so many of us to adapt and to think in new ways, and IAPB Prasad is an excellent example of an organisation that's really taken hold of that. This brings us to the end of our webinar today. I would like to thank Rohit again, and thank you to all of those of you who are watching. We hope that you found this useful. As I mentioned, this is part of a series of interviews and recorded webinars that we're doing, which are all available on our website and our social media channels. So please do visit our website and see not just those, but also the articles and resources that we have developed around COVID-19. Thank you very much.